So our panel today, we have two really esteemed physicians that I get the pleasure of working with. And first to my right is Dr. Nathan Goodyear. Dr. Goodyear is the medical director at Brio Medical. And Brio Medical is a cancer and really a therapeutic using holistic healing therapies for patients. And Dr. Goodyear has really been just a wealth of knowledge for us as a company, but also just a really compassionate healer. And I think you'll be able to really garner a lot from him and his experience in integrative oncology. And then we also have Dr. John Catanzaro. John Catanzaro is our CEO and founder of Neo7 Bioscience. He brings 25 years of experience in clinical application, working with cancer patients, and really developing our technology that we're going to talk about today, and really on the forefront of innovation for individualized peptide therapy. So I'm going to jump right in. And again, if you have questions, like I said, we'll have some time at the end, and we definitely would love to hear from you guys. So since our theme of A4M this year is longevity, I wanted to pose a question to Dr. Goodyear, which is, what do you think is the biggest obstacle to longevity?
You know, the way that's been changing over the last couple decades really has hit the forefront, really beginning in 1993, when in Alaska, actually the first state in the United States where cancer overtook diabetes, cardiovascular disease as the #1 cause of death. And then there was the 2019 study called the Prospective Urban and Rural Epidemiology Study, where it was a very large international cohort where they looked at 21 different countries and they divided them into 3 categories: high income, middle income, and low income. And they found a very stark premonition, which was that what was happening here is that in high-income countries, and even in the high-income middle countries, you were seeing cancer overtake cardiovascular disease as the #1 cause of mortality in adults. And in fact, so much so that twice the rate, cancer versus cardiovascular disease. And one of the lead authors in that, and actually on staff and faculty at Stanford University, said what we're actually seeing here is an epidemiological transition from cardiovascular disease to cancer as the #1 cause of death in adults. Now, the CDC in 2016 confirmed this data, actually pre-2019, showing that in the United States, 23 states, actually cancer is the #1 cause of death in the United States. And that includes states like Arizona, where I'm from, and California, which everybody looks at as being a very healing place. But that's what the data shows. So when you look at the data, cancer is the #1 threat to longevity as this cancer is focused on longevity.
Thanks for that, Dr. Goodyear. And John, based on giving maybe just a little background on cancer evolution, without going too much into it, but just kind of, so everybody can sort of be on the same page on really how does this manifest? Just a quick overview that maybe you could provide.
Yeah, cancer has a molecular expressive pattern, so the cancer evolution is very complex, and it's a multi-signal type of evolution pattern. And what really needs to happen is there has to be a capturing of the molecular expression fully, from the patient's data set. So what we do is we are focusing in on trying to really catch the hidden signals that are faulty signals. And we want to be able to model those particular signals and create the solution for those signals that are altered. And the cancer evolution pretty much has 3 specific phases. Some of you may be familiar with them. The first phase is the elimination phase, which is actually the defense posture of the immune system against the cancer. The second phase is the equilibrium phase, where you actually have a place where the cancer defense mechanisms have created the surveillance that they need, but then there's a space where the equilibrium is reached, but in that specific space there, the immune system needs to keep on working to avoid it from going into what they call the escape phase. So the escape phase is where most of the trouble comes in the cancer aggression, some of the advanced cancer progressions, and this is where that occurs. So what we do is we want to be sure that we can actually catch those signals, not just with the cell behavior by itself, but with the tumor microenvironment as well. And if we can when we do that, we do it intelligently profiling it, so we get the top highest level signaling targets that are unique to the patient's data expression.
Yeah, I think it's important to point out here is that this applies beyond cancer. Here, what she's got here is the hallmarks of cancer. Of course, what I do, and actually I was in A4M from like 2008 to 2015, took several years off as I dived into integrative cancer. And when you look at the hallmarks of cancer, understand that this precision, this targeted therapy that's based on these peptides, this molecular phenotyping, if you will, really it points to any disease you can think of. So when you look at cancer, what you're talking about here is this altered immunostate. Really in cancer, it's moved from a cancer concentric state to really a tumor microenvironment concentric state. And what you're dealing with here is immune dysfunction. And so when you look at any chronic disease of aging, what you're looking at is immune dysfunction. Now here in cancer, particularly talking about what John talked about with the immunoediting phase, particularly the equilibrium, a better way to think of that is cancer equilibrium, cancer immune equilibrium. So there what's actually happening is the immune system is actually holding in check the growth of the cancer cells, but at the same time, it is actually sculpting, so concomitantly sculpting and creating an environment that's pro-tumorigenic, immunogenic, so as to set the stage for cancer to grow later. And in fact, research has showed over 20 years, patients in remission, they still have circulating, disseminating cancer cells. So our understanding of this immunoediting process here versus tumor progression, tumor suppression, really applies to any disease that you may be seeing in your patients, and or, here's the big thing, preventative disease. Because when we see this process here, what you have is mass immune and cellular corruption and signaling corruption. So obviously the healing strategy there is a much bigger one than in a preventative strategy in the longevity approach.
So as we're looking at, we're giving the example of cancer. We've obviously talked about that it relates to other disease states as well. But what diagnostic tests are you using, and what do you think is really the focus and the sort of next generation of diagnostic tests that we should be looking at when utilizing peptide therapy?
Yeah, I think that the diagnostic challenges often that a lot of physicians are facing is that the list of markers on a particular patient, on the results, they're very ambiguous, or they're unclear, they're misaligned, and they're without precision solution. So you actually have a long list, but you really don't have any course of action. You don't have the application and the solution. So when we're talking about molecular profiling, you're actually capturing the complete hidden environment. You're not flying blind anymore. You're actually looking at the molecular assembly of the person's own, matrix. And when we do that by capturing everything on the Multiomics platform. If some of you are not familiar with Multiomics, it's basically capturing what we know on functional exome, RNA transcriptome, the excretion urine proteome, and the HLA immune typing. So when we look at all of these elements, for instance, even on tumor tissue, we capture the CT, cfDNA expressions, and all of this big data, when it's actually assembled, then begins to make some sense and clarity as to what behavior characteristics are unique to that patient. And what we do from there is then in our technology, the technology maps, ranks, selects, and actually filters the high confidence ranking signal factors that are actually the trouble codes in the disease process. And that's what makes this unique, because when we're talking about molecular individualization, it's a unique system whereby those root trouble codes are actually revealed. So a lot of us physicians really want to know what the root of a problem is, and we often are challenged with that there's more than one particular, it's a multifactorial type of a picture. And when you have those kind of presentations, some of you may have seen cancer maybe with two different cancers existing in the same person, and they may be totally unrelated to each other, but yet there might be some relational patterns to them as well. And we've actually had a number of patients that we've actually looked at that have those type of profiles. So really, you're taking this individualization to the next level and creating the architecture and the engineering to come up with the solution.
And it's a solution that's clinically applicable, and that's the big thing. It's having the ability to test just to test, but no clinical application doesn't help us as physicians. But the ability to actually take data, to take this really, what we're looking at here in the multiomics, that's genomics, exomics, epigenomics, we were laughing today, we recorded a podcast, immunomodulomics, peptomics, we were just making up words. But really it's just the future, yeah, they were geeking out. It's the future of what is a lot of research in the academic world, and it's making its way to the clinical application. And so what this is allowing us to do is really look underneath the hood of all of this just metabolic mess, this genomic mess, this immunomodulomic mess, and really devise a specific strategy.
One thing that I would add to that too is the molecular immunoediting features that you saw up on the slide. When we're talking about elimination, equilibrium, escape, we're talking about very complex mechanisms that include surveillance, defense posture, regulatory posture, and adaptation. Right? So what we want to do is we want to get away from the cancer evolution. We want to be able to integrate a change in the signaling so that we can get that programming effect or reprogramming effect to go in the other direction in favor of longevity and health. And you can't do that by just, there's a number of ways you can do that, obviously, and most of you in this room are familiar with some of those ways. But when you're talking about a hub strategy that really gets to the center of a signaling impairment, you're actually, you're going to be a head and shoulders above the rest because of the fact that you're really addressing some things that will never be revealed on a blood test.
And I think it's really important too, because we're seeing more and more patients coming in with two coexisting primaries. Recent patient we had with breast cancer and pancreatic cancer. One patient here recently that has a history of 5 different primaries. So what we're seeing in the evolution of this environment that's allowing cancer applies to really every disease you may see. It's going to become much more complex, and we're going to have to become much more precise, much more targeted in what we need to do as clinicians to really focus in on a healing strategy.
And so I think, from taking it from all the science that we're talking about, the technology that we're talking about, and getting it a little bit more applicable to the clinical application, how are these personalized or individualized peptides different from off-the-shelf peptides?
Yeah, many of you are familiar with off-the-shelf peptides, or what they call catalog peptides, which, there's a lot of power in peptides. I really love the peptide world. I've been immersed in it since 1996. And when you're talking about personalized peptides, what you're doing is you're looking at, again, the molecular expressions of the individual patient, and you're matching it to their own HLA in what we call the central intelligence of the immune system, basically. It's an immunomolecular platform that actually helps in being able to know what things are compatible with the patient, what things the patient is susceptible to, and what agents or engineering processes would work better for the patient. So we're not, this type of process doesn't take off-the-shelf peptides and match them to the patient. What it's doing is it's making unique peptides to the patient's own signal fault expression. So like, in other words, it's then selected. The hottest sequence of peptides are selected, and then they're nano-engineered for the design. And what we do is we choose 10 primary signal targets with 3 checkpoints in cancer to actually facilitate the change that we want to see in the patient. So it's very, very uniquely expressed to the patient. It's not off the shelf. However, now one thing I can say is that you can take off-the-shelf peptides, like in your modalities, and it will really power up your off-the-shelf peptides because of the, and then you will also know which peptide combinations that are off the shelf would be better to choose as a first priority, as opposed to just maybe putting 2 incompatible peptides together that might kind of murk the waters or create off-target reactions that you don't want.
Yeah, what I always tell my patients from a clinical standpoint, I want flexibility. I want options. And therapies like the peptides as well as others, they don't negate your ability to use other clinical modalities. Whatever you may use in the treatment of diabetes, cardiovascular disease, or longevity or prevention of disease, for me, it's in the treatment of cancer. So where we are, I run a natural, holistic, and integrative cancer therapy, where we use a wide spectrum of therapy modalities. This could even include, targeted biologics. This would include IPT, hyperthermia, and all of these therapies come to the front. So it doesn't exclude these. And of course, medical cannabis, which I'm a huge fan of, but all of these we bring to the front, and we don't have to remove any of these from the table. Bringing this to the mix really allows us to have flexibility and uniqueness in devising a strategy for treatment. But then the big thing here is to move from a treatment disease model, from a sprint to more of a marathon, to really move this transition from the process where we can start healing. And where you look at medicine approaching the treatment of cancer, of course, that's what I do, but understand almost every one of my patients has an autoimmune disease, so this absolutely applies to autoimmune disease. And in fact, if you look at cancer, in many ways, it's behaving like an autoimmune disease, where in that tumor microenvironment, which is the battlefront, the immune system is actually being turned on the immune system in many ways. So what we're able to do here is actually really move a strategy into healing. And way cancer therapy is approached today is, well, there's no evidence of disease, so now what do? Well, we'll see in 6 months. For what? Well, let's do some imaging to see if it comes back. Well, shouldn't we do something different? Absolutely. This is the difference. This allows us to stay ahead. Again, that study showing that 20 years, no evidence of disease, still circulating and disseminating cancer cells that are viable, not just particulate, but viable. So if you don't address that, every person that's in no evidence of disease situation, they are a ticking time bomb.
Yeah, and with that, Dr. Goodyear, can you maybe share a couple of cases? I know you have a couple of cases that I think might just, really bring this a little more applicable into practice.
Yeah, absolutely. When you look at the case studies, so I wanted to present just a couple examples of just the flexibility of what these peptides allow us to do from my clinical standpoint. And again, where I am at Brio, we have an incredible team. There's another physician. I'm an MD and an MD homeopath. There's another MD with us that does targeted therapies. We have two naturopaths here, which I want to mention Dr. Labont, who I think is here. She's incredible. And we also have a nurse practitioner, great staff. But anyways, we see a wide spectrum of diversity of patients. So this particular patient right here, CK, she was diagnosed with stage 4 ER positive, PR negative, HER2 negative. Now what's interesting about this, she was initially diagnosed in 2020. She went down to Mexico. They did a bilateral mastectomy. They did bilateral lymph node dissection. She ended up having 9 of 23 lymph nodes positive. They declared her cancer-free. Yeah, that's not what happened, because just a few months later, in the summer of 2021, she was diagnosed with metastasis to her right eye, where she lost her vision. Then she went to a clinic nearby where I was in the Valley of the Sun, and underwent some treatment. But then what they noticed is that the cancer has actually spread. It actually spread to her bones, to her liver, and to her lungs. And it hadn't just spread a little bit, it had spread a lot. So she then went to a clinic in California, a great clinic over there, underwent 24 treatment sessions with low-dose insulin-potentiated chemotherapy, and the cancer still spread. So she actually presented to our clinic in May of 2022. And when she presented to our clinic, she was in a wheelchair. She could barely get around just with a walker. Now, when I present case studies, I always try to be real, Because we all know when we've gone to lectures and we hear case studies, it's like, oh, that sounds a little bit too good to be true. So, so I want you to understand the impact here, because I was actually at my church and she walks back in the back at the end of the service and she can barely walk and she has to sit down. Ends up going to the hospital, and this is 2 days after we saw her, 2 pathological fractures, terrible pain, ends up getting stereotactic radiation. You can see what we did with some of the treatments. Her initial presenting tumor markers, tumor markers you have to be really careful, but what you can see is her CEA, good marker of angiogenesis, significantly elevated 46. You can see her breast-specific tumor markers, and you see her CA15-3, 414, and CA27, 29, 720. 30 and less than 38 respectively is where you should be there. So clearly we have a massive, massive issue. You can see with the PET CT scan, particularly at that T2, she had significant osteosclerotic fracture there, terrible pain, couldn't walk. And then so what we did is we did get radiology oncologists involved. Again, conventional medicine has something to offer. Though I practice natural, holistic, and integrative, I think it's important to understand somebody breaks a hip, we're not going to tell them to go take more vitamin D. That's silly. We need to understand where everything has a benefit. So we did some stereotactic radiation. She got on some targeted HER2 therapy. We put her on aromatase inhibitor, postmenopausal, put her on some repurposed medications. You can see there, use T3 because of the non-thyroidal illness syndrome, and then of course put her on a bisphosphonate because of the bone metastasis. So then, obviously, too, this is what a report looks like. So she had on, Shannon had on the original slide or precursor slide there, the process of these peptides. So in this process, there's really kind of 3 phases. There is the peptide testing phase, where in this case, we do testing of the tumor, we do testing in the blood and testing in the urine. And this process does take some time to get back, but it's precision-based. Then from that process, you move into peptide design and then into peptide manufacturing. And what you can see here is her actual report. So what we're seeing is the top 10 markers that are evaluated, that are picked up. And what you see in the report is actually her specific dysfunction or manifestations, as well as how that fits into those hallmarks of cancer. And if this may be new to you, that's okay. Areas to learn. Lots of hyperlinked areas out there take you to studies to discuss the application of it from an evidence-based standpoint. But I know at NEO7, they also have practitioners there. They have the ability to answer any questions you can have. So from this process, we then moved in to a new realm of treatment. We brought in the custom peptides and brought them in with our treatment strategy. So she has now subsequently received 4 cycles. These cycles are almost, think of them almost like a chemo cycle, but it's just peptides. We would do IV and IM peptides, but we are still mixing in high-dose vitamin C and mistletoe. Now, the first 6 weeks, we did 2 cycles back-to-back, 3 weeks and 3 weeks. And we continued with the high-dose vitamin C, alpha-lipoic acid to augment that, photodynamic therapy, IV mistletoe, melatonin, love melatonin, and you can see off-the-shelf peptide, thymosin alpha-1. Okay, so still using that, but using it aggressively. And what you can see now, her and her husband's name's Dave, just love him to death. They live in upstate New York. She walks. Not only does she walk, she doesn't use a cane. Not only does she walk, doesn't use a cane, she walks on her farm where it's uneven. Not only does she do that, she has 0 pain, none. So what you can see on her tumor markers, now this was just from about 3 weeks ago. So she's now taking 9 weeks off, and she will come back after that 9 weeks, and we will do another 3-week cycle. And what you can see is her tumor markers, her CEA dropped from 46 to 15.5. Now, still elevated, okay? So, but she's making that transition. She's making that transition from an acute sprint disease. She's reclaiming her humanity. She's going home. She's being a grandmother. She's being a wife. She's getting back into living again. And you can see the CA15-3 down from 414 to 48.8. Incredible. You look at her CA27-29, 720 to, what is that? 92.9. That's a typo. That's 30. It's supposed to be 29.9. Sorry. So when we look at those biomarkers, we go, wow, that's incredible. But what does the CT show? Well, she still has more work to be done. So I don't want to present this as, she's cured, because that's not a clinical endpoint that we can scientifically validate. But what we're seeing is a massive reduction in her FDG activity associated with these tumors. Not only that, in her lungs, a lot of these became non-reactive. They weren't uptaking any sugar. The SUV had dropped to normal. And you can see in these other areas, in particularly the lymph nodes, the standard uptake value had dropped significantly. Now, she still has areas in the bones that are still very hyperactive, but significantly less. But here is the perfect example of what this patient is doing. She is making a transition. Instead of playing the short game, she's now transitioning to the long game. She's returning to being who she is. She's losing that label of a patient, and she's returning to who she is as a mother, as a wife, as a grandmother. And let me tell you what, seeing her in the clinic is just an absolute joy. So that's one example. That example is obviously the worst case scenario. That's a stage 4, wildly metastatic, multiple times, received multiple treatments, and deteriorating. She was significantly deteriorating when she presented to our clinic. This case is a little bit different. This is much more of a, you don't know she's sick. You don't know she has any disease. So this would fit in almost any other realm of chronic disease of aging that you can think of, that they don't have that significant clinical visual picture of being ill. So this patient, wonderful lady, 52-year-old with left breast cancer, first diagnosed in March 31st, 2022. You can see she's ER/PR positive, HER2 negative. This is an invasive intraductal carcinoma of her left breast. Now understand these images are not the patient, but what you can see here in this image is a left breast cancer. She did have one left lymph node that was suspicious. Tumor markers, not elevated. Not elevating. Overweight, chronic inflammation, elevated CRP, but this is a person that doesn't fit the clinical profile of somebody being deteriorating and ill. So what we did is we approached a very natural and holistic approach using high-dose vitamin C, pharmacological vitamin C treatment with mistletoe. She refused insulin potentiated therapy, but we were able to really move in a very holistic and natural approach. So what we now see, and from that standpoint also, we knew we wanted to make that pivot. We knew we wanted to make that turning point. So we began that phase of testing. We began that phase of design and manufacturing. So her PET CT on repeat showed actually a resolution of really the standard uptake value of the sugar, and it dropped from over 3, I think it was 3.7 or so, down to 0.7. And the only inflammation there was around a surviving clip that they had placed there. I've actually had 2 patients where they put those clips in near the breast biopsy, and they end up getting those taken out, even though there's nothing there and there's no tumor there. So I don't understand, when we have immune dysfunction, why do we put a foreign body right in the middle of that? That makes no sense, but that's another topic for another day. So what have we done with her? Well, we've started her on the peptides. High-dose vitamin C, she's still getting alpha-lipoic acid, mistletoe, aromatase inhibitor therapy. But what we've done is we've now transitioned her into the customized, personalized, targeted peptides. Now, she's received 1 cycle. She'll be getting her next cycle coming up in about 4 weeks or so. But you can see we're still continuing the off-the-shelf peptides with the thymosin alpha-1. We're still continuing here the sub-Q mistletoe, and also taking the IV mistletoe and mixing that with the pharmacological vitamin C. Based on her plasma levels, she's getting about 150 grams each time right now. And so, but we're still, you can see the flexibility here. We're giving her oral metronomic chemo with low-dose interval capecitabine as well as Cytoxan. So she kind of got a little spooked after we went through the initial phase of treatment. She said, well, I think I want to do low-dose chemo again. It was like, at that point, we had that PET CT scan that didn't show the need for that. So we opted to go for the oral route, taking an oral low-dose oral capecitabine and Cytoxan. So this patient never looked ill throughout the treatment, has never looked ill, and now doesn't look ill. So this is a very clinical application to, I think, any of the chronic disease of aging patients you might see, or even longevity and prevention.
Thank you for that, Dr. Goodyear. And, John, that brings up a question. We were talking a lot about cancer today. What other applications are physicians using Neo7 Bioscience Designs for in the creation of peptides?
Yeah, we're actually seeing autoimmune cases, neurodegenerative cases, and then cases of mystery illness type cases, cases that actually have some real strong inflammatory components to it. The interesting thing about that is that every disease actually presents its own hallmark, right? So cancer has, when Hanahan and Weinberg came up with the initial 8 to 10 cancer hallmarks. And now there are actually 15 cancer hallmarks. Currently, there's about 20 hallmarks of aging. And then each disease itself has its own expressive hallmark pattern, right? So when we actually are talking about this molecular design aspect, an autoimmune disease takes a little bit of a different route because we're dealing with some significant destructive inflammatory activity that we actually focus in on, right? And then neurodegenerative, the same, not just amyloid plaques and some of those type of issues, but also neuro-related inflammation that is, probably never detected on any imaging, but you can actually see it on the molecular design patterns, right? So you can pick up on, okay, well, this patient, is definitely not only showing these particular gene protein signals, but they're also excreting some heavy proteins that are related to neurogenic degenerative activity. So the thing is that's when we work with these different type of disease sets, we can. And here's the other thing: is that one of our patients that's on this actually noticed her autoimmune symptoms actually declining rapidly to where she now does not have any more of the skin lesions, no more of the end, extreme inflammatory processes. She was in agony for many years over that, and she notices that not only is her cancer being addressed, but the autoimmune aspects are also being addressed as well.